This is QD Clinic. QD Clinic is brought to you by RheumNow.Live. RheumNow.Live 2023 is going to be in March. Hope to see you there. Our case is septic arthritis that needs to be treated in the future. 36-year-old woman with RA and a history of 2 prior episodes of septic arthritis. And now she comes to see you. She's on 10 milligrams of prednisone and she needs a DMARD. The question is, what do you use? Number 1, well, think about it. What are you going to use? Are you going to use a conventional DMARD? Methotrexate, hydroxychloroquine, leflunomide, azathioprine. Going to use a biologic? What if that she developed these septic joints while taking a biologic? Would you use a biologic again? What if she got these septic joints prior to the biologic era? Would you use a biologic in the future? Does the biologic even factor into this? My answer is probably not. And let me explain. Number 1, if you had a septic arthritis, and God forbid a second one, well, if you've had a septic arthritis, true septic arthritis, you're more likely to get it in the future. And it's more likely to be severe the second time around, maybe even life-threatening. This patient's had 2 prior septic arthritis events. She's likely to get a third, and it's likely to be life-threatening in the future. How do you protect her against septic arthritis? You need an extensive workup as to why she's getting septic arthritis. You want to do an echo, you want to do blood cultures, you want to send her for immunodeficiency, you want to look at the implants, if she's had any implants that would seed into these septic joints. You know, you got to look for a reason, something that you can decrease her future episodes of. You want to look at her dentition. I mean, there's a lot of things you got to worry about. Treating her with anything is risky, period. What's the most risky thing you can do? Continue to give her steroids. Steroids are the number 1 risk factor beyond the activity of RA. The biologic and the DMARD, that's like number 4, 5, or 6 on the list. Who's at really great risk? If the patient's under age 60, like this one is, has no other risk factors for septic arthritis, there's not much difference between whether I give her a DMARD or a TNF inhibitor or another mechanism of action biologic or a targeted synthetic. There's really no difference. If she has a prior history of serious infections and she's under age 60, there's a small risk, like the risk goes from like 6% without a TNF inhibitor with a DMARD to maybe 9% with a TNF inhibitor. But which drug is going to control her disease better? And I'm assuming you're getting the patient off steroids. However, if she's over 60, has 1 or 2 prior SIE events, and has other comorbidities, now you're talking big-time risks. Her risk of getting a septic joint or another serious infectious event in the next year is somewhere between 15 and 25%. And if you give her a TNF inhibitor, it goes as high as 40%. So there, the biologic may not be the best choice, meaning in the worst possible candidates. But again, I want to underscore, it's steroids that you got to worry about. Next, you got to reduce the risk factors that you can reduce for future infection and work this patient up so that she doesn't get a third infection. And lastly, if she's an ultra high risk patient, I don't like the idea of going safe in her because she's a high risk patient. She's probably going to have very active RA. I try to control disease at all costs. But yeah, I might be talked into DMARDs and a combination of DMARDs as opposed to putting on a TNF inhibitor or abatacept or whatever. What biologics might be safer than other biologics? Maybe abatacept, maybe anakinra, but you get SIEs with those infections as well. There's nothing particularly damning about TNF inhibitors here. They're just as bad as everything else. That's it for this QD Clinic. Tune in for more.